Good day, this is Professor Will, CBMD PhD, and today's Thursday, January 6, 2022. It is 7:14 and 23 seconds, p.m. Eastern Standard Time. Today's research, aspirin. So let's hop to it here. Researchers urge, prescribe aspirin based on benefit, to risk not age. Date January 5th, 2022. Source, Florida Atlantic University. Recent guidelines have restricted aspirin use in primary prevention of cardiovascular disease to patients under 70, and more recent guidance to patients under 60. Yet, the risk of heart attacks and strokes increase markedly with age. Researchers urge that to do the most good for the most patients in primary prevention of heart attacks and strokes, healthcare providers should make individual clinical judgments about prescribing aspirin on a case-to-case basis and based on benefit to risk not age. They conducted an updated meta-analysis which has the results of the 4 recent trials to the previous comprehensive meta-analysis of 6 earlier major trials, and aspirin produced a statistically significant 13% reduction in cardiovascular disease with similar benefits at older ages in each of the individual trials. And there has been considerable confusion from recently reported results of 4 large-scale randomized trials of aspirin in high-risk primary prevention subjects, and 2 of which showed significant benefits of aspirin, but the other 2, based mostly on poor adherence and follow-up, did not. As a result, healthcare providers are understandably confused about whether or not to prescribe aspirin for primary prevention of heart attacks or strokes, and if so, to whom. Any judgments about prescribing long-term aspirin therapy for apparently healthy individuals should be based on individual clinical judgments between the healthcare provider and each of his or her patients that weighs the absolute benefit on clotting against the absolute risk of bleeding. For long-term use of aspirin or any over-the-counter drug, patients should consult their primary care provider. The authors say that primary care providers have the most insight and knowledge to make appropriate recommendations in collaboration with their patients. An acute heart attack should receive 325 milligrams of regular aspirin promptly and daily thereafter to reduce their death rate, as well as a subsequent risk of heart attacks and strokes. In addition, among long-term survivors of prior heart attacks or occlusive strokes, aspirin should be prescribed long-term unless there is a specific contraindication. In primary prevention, however, the balance of absolute benefits, which are lower than in secondary prevention patients, and risk of aspirin, which are the same as in secondary prevention, should be an individual clinical judgment. The authors emphasize that the increasing burden of cardiovascular disease in developed and developing countries underscores the need for more widespread therapeutic lifestyle changes, as well as the adjunctive use of drug therapies of proven net benefit and affordable costs in the primary prevention of heart attacks and strokes. The therapeutic lifestyle changes should include avoidance or cessation of smoking, weight loss, and increased daily physical activity, and the drugs should include statins for lipid modification and multiple classes of drugs likely to be necessary to achieve control of high blood pressure. While patient preference is always important to decision making when the absolute benefits and risk are similar, patient preferences assume increasing importance, and this may include consideration of whether the prevention of a first heart attack or stroke is a more important consideration to a patient than their risk of a significant gastrointestinal bleed. The authors note that individual clinical judgments by healthcare providers about prescribing aspirin in primary prevention may affect a relatively large proportion of their primary prevention patients. For example, metabolic syndrome, a constellation of overweight and obesity, hypertension, high cholesterol, and insulin resistance, a precursor to diabetes mellitus, affects about 40% of Americans aged 40 and older, and their high risk of a first heart attack and stroke may approach those of patients with a prior event. And general guidelines for aspirin in primary prevention do not seem to be justified. As is generally the case, the primary care provider has the most complete information about the benefits and risk for each of his or her patients. According to the United States Centers for Disease Control and Prevention, more than 859,000 Americans die of heart attacks or stroke every year, which account for more than 1 in 3 of all U.S. deaths. And these common and serious diseases take a very large economic toll, costing $213.8 billion each year to the healthcare system, and $137.4 billion in lost productivity for premature death alone. Good day, this is Professor Will, CBMD PhD, on microbiology, bioinformatics, and pathophysiology. This video was created for educational purposes only. Hope you enjoyed listening. Until next time, have a great day.